comments or questions, we are going with Professor Francesco Costa from Italy, and he will talk about microdiscectomy. Francesco, welcome.
Thank you very much. Thank you very much, Enrique. And happy to see all of you. Thank you also for the kind invitation. Just one moment that I share the monitor. One moment. Well, I am here, but I need the authorization to the organizer to share the monitor.
1 second, let me do that.
Yeah, sorry, but it's the first Zoom with the new computer, and I need to authorize all the.
You're the co-host now. Go on.
Okay, perfect. So desktop is over there. Now I think you see my presentation, not? Oh, yes.
Okay.
Is okay? You see my monitor?
Good.
Okay, perfect. Sorry, really sorry. Apologize for the inconvenience. So we have seen with honor that the disc herniation may help by itself. Sorry, 1 second that I so minimize the zoom option. So when the aim of the surgeon in lumbar disc herniation is first of all to relieve pain and the symptoms of nerve damage instead of a curative effect of this degeneration and reversing the herniation. So must be very clear to the patient that what is the aim of the surgery. If we see on the PubMed in the last 10 years, we observe that there are hundreds of papers regarding these topics, and more than there are 13 guidelines or recommendations published till 2021 on this topic. We can see the recommendation for the North American Spine Society, but all the other and are almost all similar. But first of all, when and why is an indication? There is an indication timing for the surgery. We have seen that the main process for the disc herniation is the spontaneous regression according to the different type of disc herniation is up to 95% for disc sequestrectomy and fall till 13% for the disc bulging. So we must be very aware about the role of the surgery and define what kind of patients are suitable for this, because natural healing of the disc herniation is possible, as Honor showed to us. But when we start to speak about surgery, when there is some neurological deficit, the sensorial deficit, the main deficit is the motor one, or if there is the carna equina syndrome. In this case, there is no to discuss about the role of the surgery, but about the timing of the surgery. Again, with the surgery, we have a faster relief of symptoms, and if there is a motor deficit, there is the opportunity to reduce the entity of the disc of the motor deficit. The median time to have an improvement is stated around 6 weeks, according to the severity of the motor deficit. There is some review like this one that put the role of the surgery till 6 months. Probably is too long time. In fact, this recommendation is a very weak based on a low quality evidence. So the conclusion regarding the role and the timing is that surgical intervention is suggested prior to 6 months in symptomatic lumbar disc herniation where the symptoms are severe, but an early surgery less than 6 weeks is suggested in case of severe motor deficit, while if there is a carna equina syndrome, we have to speak of emergency surgery. This is the statement that we wrote and are proposed on the WFNS spinal committee. And again, the early surgery is suggested in case of major motor deficit. There are different type of surgery option, ranging from the microscopic, the endoscopic, minimal invasive. So which is the role of minimal invasive surgery? The gold standard that is recognized right now in the literature review is the microdiscectomy, because there is more history and more literature about this. Is a standard interlaminar approach. I can show just a very quick video regarding the surgery. So we prepare with the space just to have the exposition of the ligamentum flavum and a little part of the upper lamina. The steps are to detach the ligamentum in order to arrive in the dural sac to, I perform a flap of the ligamentum flavum, but we can remove in a different way. Once we have the dural sac, we have to check where is the nerve root and where is the disc herniation. So we gently retract the disc herniation, the dural sac. We have the exposition of the disc herniation. Then we proceed with the microdiscectomy. We remove the disc herniation, then we can perform a microdiscectomy. This is the standard microdiscectomy that is considered the gold standard for the history. If the disc herniation is in the foramen or extraforaminal, we can approach by a lateral approach that is the most used for endoscopic surgery. Here you can see the Casper retractor, but it's quite similar for the tubular. But as said, in the last year, minimal invasive procedure, surgical procedure, gain more popularity in order to reduce the risk and the invasivity to the patient. So we can observe that in the last decades, the minimal invasive tubular and percutaneous endoscopic procedure grants a very good and similar result, and the trend in the last year is for another indication for this procedure. Also, if we need more studies in order to show that this procedure is better than the microdiscectomy. But the last, you can see this review that is based on 2021 with more recent data. The results are a little bit better than the microdiscectomy, and there is really several studies. So right now it's quite impossible to rank one type of treatment over the others at the present time. Also, if a minimal invasive procedure for extraforaminal disc herniation appear to have similar safety profiles but lower operative blood loss, operative times, and a faster return to work, that are very important data right now. Efficacy and safety outcomes do not support right now the use of tubular discectomy versus open conventional discectomy. So it depends also from the center. Regarding the statement that the WFNS spinal committee proposed, is that although minimal invasive procedure have short-term advantages, there is insufficient evidence to make a recommendation for or against the choice of a specific surgical procedure for lumbar disc herniation. So we need more studies. But when we have to perform a sequestrectomy or a microdiscectomy, in the literature there is no universal consensus. The results are quite similar. There are several papers regarding this, so there is similar results in terms of recurrence. So it mainly depends from the anatomy. So we cannot make any conclusion about one technique with respect to the other. So it depends. What is the role, or if there is a role, in a surgical fusion for a disc herniation? Obviously, for first disc herniation, there is no recommendation about a routine treatment with spinal fusion. So the literature regarding this is quite similar. There is a little bit of changing in case of recurrent lumbar disc herniation. So in this case, a fusion surgery may have a role, but we have to strictly define if there is sign of instability due to the recurrent disc herniation. And the lumbar fusion So it's not recommended as a return treatment following primary microdiscectomy, but may have a role in patients with herniated disc who have evidence of significant chronic axial back pain, severe degenerative change, or instability associated with the radicular caused by herniated disc. Thank you very much for the attention, and again, sorry for the delay of starting my presentation.
Thank you, Francesco. Very nice presentation. And we open for the questions and comments to the audience.
Francesco, may I ask
Can
you?
you unshare
Yeah,
the
yes.
screen, please? Francesco, unshare
Yes.
the screen.
Yes.
I have to share? Or...
No.
okay.
Please.
Is on share now?
No.
Not
Oh, yes. Now it's on share. Sorry.
It's okay.
Francesco, thank you for the excellent presentation. I never asked you, but I don't know. What do you think about interspinous devices in microsurgery of the disc? Do you use it? Do you contra? Or what's your opinion?
No,
and your experience.
I don't know. I don't use right now. In the past, in around 2000, there was a dynamic interspinous process, but right now the literature is suggest to do not use this dynamic interspinous process, and in Italy are not more allowed. There are diffusion interspinal interlaminar and interspinous process devices, but the indication is quite similar for spinal fusion. So for a disc herniation, in my opinion, for a forced disc herniation, fusion is not required, except for the case where there is a clear sign of instability and the disc herniation is a sequence of a disc instability, but usually we see the spondylolisthesis with a disc herniation. That is a different topic in my opinion. So for disc herniation, for a first disc herniation, there is no indication for fusion. If in a recurrent disc herniation, a fusion may be required, can be used, but in young people, I prefer to perform a skew fixation and use a cage to obtain fusion, because it's more solid than respect the interspinous process. But in case of elderly patients, it's a less invasive procedure, so can be considered. I don't love it right now.
I think, there's lots been said and written on it, but unfortunately, it's not proven that it really works. And secondly, it's kyphogenic. So majority of the people who know about biomechanics do not use it. And, there are people who are marketing it. And, once marketing comes in, there are some people who may be using it. I used it in few patients, but realized I was doing a mistake and I stopped using it. But it may be some particular group of patients that may be effective, but we really don't know. There is not enough data out there, really scientifically good data to say that it really works.
Yeah,
there is
we
a
can
question
use
for you.
probably in addition with a discectomy and a cage fusion in order to reduce the because we know that the biomechanics of the lumbar spine is mainly based on the disc level. So for obtaining a fusion, we need to put a cage. So in this case, we can add an interspinous process in very selected patient, elderly patient, where a skew fixation is not indicated. But with the less invasive percutaneous procedure, I think is not a make sense.
The problem
is my opinion, obviously.
Failure rate is up to 25% in these, and they're hanging out, and there are a lot of problems. So I'm not sure if something which is dubious may not be the best thing. But there's a question for you. Do you wait for 3 to 4 weeks in foraminal disc herniation that is causing severe pain? Not super reluctant to pain medication, however, without any muscle weakness. So would you still wait for 3 to 4 weeks even they have pain?
If there is not a severe motor deficit, you can speak with the patient also, because you know that with the removal of disc herniation, you relieve the pain and also the disability due to the pain with the patient. You have to speak with the patient and explain that is an option, also with a less invasive surgery is remain a surgery, but with very active people that need to maintain its work, and the pain medication is not effective, may be indicated before the end of the 6 months, also because usually it's very young people, active people, so may be a solution, but is an elective indication, so must be indicated patient by patient, and must be explained what is the role of the surgery. That was my first slide, because sometimes the patients understand that with the surgery they heal completely from the disease of the disc, but this is not true. So I think it's important to explain to the patient, but it's an option, and you know that you reduce the time, especially if it's a bulging of the disc and not a sequestract disc herniation that may be healed without surgery.
Yeah, there are a selective group of patients that you could do that, but generally speaking, no matter how much the pain is, nearly always, you can bring the pain down. There may be maybe 10 to 15% of patients in whom pain is not going to come down, and you may have to do something for them. But I think you should try. I think there's a bias from our perspective being surgeons, so I think it's important that we take that bias out.
Exactly.
There's another question. How often do you use flexion extension X-ray after laminectomy and discectomy?
For primary disc herniation, I use dynamic X-ray if on MRI I saw some indirect sign of instability. For recurrence, I use in every case in order to reduce. After or I use primary with a primary disc herniation, the X-ray, if the back pain, the axial back pain is a very relevant symptoms like the radiculopathy. So I try to manage, but usually is not the first choice. But I look very carefully the indirect sign of the MRI and the clinical symptoms of the patient.
Okay, thank you very much.
Thank you.
Francesco.